All right, so I am here with my friends from PowerStep. So Mindy and Mercedes work at PowerStep. They're here to answer any product-related questions if those come up at the end. And PowerStep is sponsoring this webinar. Dr. Freels is our awesome speaker. And she's the founder of Lexington Podiatry and key figure at Toe Tactics, Podiatry Innovators Hub, where she's committed to advancing foot care through a fusion of traditional practices and cutting-edge treatments. As a faculty member at the University of Kentucky and MedBridge Global Academy, she focuses on integrating regenerative medicine, particularly the therapeutic benefits of peptides, to enhance healing and recovery in her patients. Additionally, she is the creator of Modern Podiatrist, a premium prescription strength foot care line designed to meet the needs of today's active lifestyles. Renowned as an expert in her field, Dr. Freels is dedicated to providing comprehensive, personalized care while actively contributing to community health initiatives. All right, so without any other distractions, I am going to turn it over to Dr. Freels, and I'm going to turn off my camera and mute myself, but I'm here listening, and let me know if you guys need anything. Take it away.
You got it. All right. Well, I think everybody knows what tonight's all about is how to utilize Morton's extension inserts in your practice. I really wanted to focus on not only like some of the details and the nuances of this particular product and why it's, to me, optimal on the market for our patients, but I also want to talk about, who is this patient, who is this built for, and who is it not built for? Because there is a massive difference, and if you select the wrong candidate, obviously we all know that's going to be negative reviews, negative feedback, things like that. So I just kind of want to separate those two categories and give you some tips on what to avoid to just kind of save yourself and your own reputation. And then of course, integration into your practice. So the first thing is let me move this little window here. It's in my way. Hold on. Okay. Here we go. Okay. So the carbon fiber plate that's underneath that first MP joint, it goes all the way to the end. It's definitely firm. So we don't want a lot of flexibility here because it's not going to optimally offload it. There is another option out there that I'm going to discuss on the next slide, and why this one is going to be a little bit better for our patient. But it also contours the arch, which is pretty rare for any type of carbon fiber extension on the forefoot. To me, I think it's important to always have that arch support. Also, I love they have cushion. A lot of these carbon plates are really thin, which I love for shoe gear. It's highly versatile into different shoes, but this doesn't have too much cushion. And a lot of people that have foot issues, and specifically, arthritis and things like that, if it's a real hard material, they're really struggling. They're trying to put it underneath their insert. They're trying to figure out how to have enough volume in the shoe. So to me, I love being able to rip everything out, even if it's in a glued down insert or something that's even stitched in. I literally just rip it out and put it in there because it's not really serving anything. It's just kind of a cosmetic feature to me. And then, of course, we'll go over what exactly it's doing to the first MP joint and why it's important. All right, so with the carbon plate, you absolutely have to have it as firm as possible in this particular area. Definitely looking for someone that doesn't have too narrow of a foot. To me, I think that if that's super narrow, you're going to get some imposition on the second met head. So make sure that that person has at least a medium width foot. I love the cushion. The cushion is going to be absorbing shock. So we know these patients are going to be arthritic. They're jamming that joint. So the cushion to me is great for shock absorption. Again, a lot of the other products, and I'm thinking of really the main one is the one we were carrying beforehand, which is this thin carbon graphite plate, which patients loved it. But again, they were struggling to fit it into their shoe. So this combination of the two cushions, our patients are really loving it. But the main feature here, heel strike to toe off. It's going to be a nice smooth glide because what's happening now is, obviously heel strike, they go toe jam. So when that toe jams, they then compensate. They have to move laterally. So that's going to give them false metatarsalgia simply because the first MP joint doesn't work. Also, you're going to see a lot of perineal issues, any lateral ankle joint instability. So to me, that is a lot of kind of what's missed and not addressed. And is it Hallux limitus? more Rigidus, or is it truly a functional Hallux Limitus, which should be treated in a different way? So again, discerning between those two demographics is critical. So by having this material, you're really going to be able to flow over that joint that's already damaged. Of course, you're going to reduce inflammation. The jamming, we already said, it's really going to help you propulse through to toe off. I often recommend pairing it with, say, a Brooks Ghost Max 3 or anything that has a 4-foot rocker to it, because that is the issue. If you put this into a shoe like a Skechers shoe that's super flexible and flimsy, you're not going to get the maximal benefit out of this. So to me, evaluating shoe gear is just as important as doing the biomechanical exam to pair those two together for optimal success. So again, you don't want anything that's too flexible. And often I will show the patient, if I can roll it up like a burrito and stick it in my pocket, which sadly a lot of Skechers, the older versions of Skechers and the cheaper versions of Skechers are horrible for that. This insert will improve that. So I think that there are a lot of this demographic that they didn't really want to buy, new shoes and things like that, more the geriatric, and they like the lightweight, the slip-ons and things like that. So it'll definitely improve the quality of the shoe. It also increases the duration of the length of the shoe lifetime. So that's something I always tell our patients that, you may now get, 3 months out of a shoe, which is crazy to me, but 3 months by adding some type of insert, custom orthotic or, OTC insert, it really changes how that foot is or how that shoe is wearing, the wear pattern. So you can really get a longer use out of it. Of course, we all know, hopefully at this point, a Morton's extension is reducing that range of motion to the joint, really offloading it. To me, it's like a springboard, if you will. We don't want range of motion there because any range of motion is denuding or wearing away that cartilage. That's where their pain is coming from. So as that cartilage is denuding, they're getting more inflammation, they're getting more synovitis, and that's just more bulk and more arthritic buildup. So taking that pressure off at an optimal time, to me, makes sense. So it reduces their pain. Thus, they're happier. Talked about the 4-foot rocker. The arch support. I love this design because we need arch support. So if you think about how the first MP joint is functioning, right? We know it's limited. It's not anywhere near 65 degrees. For whatever reason, we need to make sure that they stay on that first ray during toe off. So to me, having an arch support there that's not too rigid, that's a little bit, it's firm, but it's like a little bit flexible. They can easily roll over that, and they like having that arch support. To them, it's almost like a hug going over the forefoot. Otherwise, you have so much dead space in the shoe, so much area that's not being utilized, and we feel it. You're going to get that midfoot drop. If you can imagine, here's your heel and here's your toes. When you stand up, what's it do? Boom, it collapses down. So that arch really reduces arthritis in the midfoot. And if you think about it from a clinical standpoint, if you have arthritis in your first big toe joint, likely you have at least mild to moderate, if not severe, arthritis in the midfoot. So why not support that? Because we all know arthritis needs supported. So, all right. So we talked about the arch shell. It is in a neutral variety. I really am a huge fan of ProTech for the variety of low, neutral, high arches. Personally, maybe that'll be something that comes up, I think, with enough demand. But again, this fits most patients, and those patients typically aren't super active, in my experience, that have this type of issue with their big toe joint. Again, we talked about how the little bit of a flexibility in the arch. The big difference between this insert and a carbon graphite plate is it's going to have a heel cup. And if you know, the rear foot is the brains to the foot. You control that rear foot, and the rest of the foot, as much as possible, structurally, is going to follow. So to me, having something that's completely flat is not allowing any type of support here. So the forefoot's just going to be all over the place. So to me, you're really not going to get that true propulsion that ideally you're looking for, simply because you're not controlling the rear foot. But cushion. We talked about a couple, the dual layer of cushion. Again, shock absorption is key. These people have arthritis, they have inflammation, they have pain. Likely with Hallux Limitus or Rigidus, because again, it's a joint jamming, it's a compensation issue where they internally rotate. They are riding on the 2nd through 5th met heads. So they're going to have increased pressure. And if they have a plantar flex met head, say 1 or 2 millimeters, they're going to automatically start feeling that. So if you have a patient coming in that's complaining about, a different metatarsal head that's bothering them, my recommendation would be, number one, to add a metatarsal pad onto it, or number two, what I do is take lipstick and I just match it up to that met head that's painful, and then I will mash it against the insert and then hole it out. I literally will just take a scissors and I cut a hole in it, and they're very happy. So that is one way to kind of minimize any other, any issues coming up from a clinical standpoint that's creating other issues. The top cover really reduces sweating. It's antimicrobial. It's got everything you need in terms of cushion. It's not going to be like, sometimes they're just too thick, and the volume in the volume that's taking up the shoe isn't ideal. And I mean, a lot of patients throw it back to us like, I can't fit in my shoe. To me, this insert is able to pull off the Morton's extension with a little bit of cushion. So it's continued to kind of do everything it kind of needs in terms of just having that flat plate, which, again, some people love it. I just know that they struggle with finding how to make it work with their shoes. So just kind of I like having all of it together. Um, and not just having like the insert. So if you're talking about the first big toe joint, what else is going on? Is it someone that is getting early onset arthritis? Is it someone that's having a bunion issue? What's going on? The joint is being damaged. So often I will inject peptides into the joint itself to not just mask the pain, obviously with steroid. So my goal is to repair and heal it. Am I going to reverse it? No. Am I going to help the pain? Absolutely. So anyway, this is just a side note on kind of combining the two and kind of thinking outside the box. Like, okay, yeah, here's an insert. You can throw that at them, but what else can you do from a more conservative standpoint that will help them with true cartilage regeneration and, increase tissue repair, decrease pain. So bunions, obviously, with bunions, to me, if you have a bunion with an elevated first ray, that's when you're going to want to use this. If you have a bunion that's super flexible and you have that hypermobile patient, I would not select this particular insert for that. I would actually go for more of their ProTech or Pinnacle line for PowerStep personally, just because you don't want to limit that range of motion, and that restriction is going to make that bunion painful. Because if you have a patient coming in with a huge bunion and they have no pain, you evaluate them. Typically, it's of that flexible nature. They're not getting that joint jamming. They're not getting that pressure on the joint, which is the initial issue, right? So what I do is I have them do like a lot of flexibility and stretching of that capsule, continue range of motion, and if indicated with, again, that elevated first ray or first metatarsal, then this will be a great insert. Otherwise, you're going to go a different route, which you'll see in just a second. Hallux, Rigidus, Limitus, very obvious. I hate that Hallux Limitus to me is lumped into one category, because to me, I think that there should be like a Limitus, no really reduced range of motion or a little bit of range of motion, because you're either going to go left or right based on that physical exam. This is, to me, the number one clinical exam that is missed in creating orthotics, or I guess not missed, but not corrected in an orthotic, because I see a lot of people coming in and like, I hate these. I brought these from another podiatrist. Here's a whole bag of inserts and over-the-counter or orthotics that have not worked. And I look at them, I'm like, it's missing a critical feature. For this, if you're not having or any range of motion that is painful to the patient, go Morton's extension. If it's just not moving, you're kind of forcing it. And when you do that, so what I do is try to plantar flex the first ray or first met, and then I push on the hallux. And if they're like, that hurts, then I know I need to offload. So I tell them, like, we're either going to continue and preserve range of motion, or we're going to offload. And oftentimes, one foot needs this and one foot needs that, which is the most frustrating part. But If it's bilateral, then this is an obvious solution. So of course, the whole goal is to glide over easier. As a big Bengals fan, I'm really sad about yesterday and my man, Mr. Burrow, getting his turf toe and ruptured ligaments. I don't even know the story, but that is an obvious short term for an athlete to use. So if you have any child that is playing sports or even not, maybe they just jammed it on the trampoline or something, put them in something like this just temporarily to take the pressure off of the joint so it can calm down. You can ice it and do all the other stuff. But ideally, or my biggest demographic for this particular insert is the older demographic with arthritis. They need something easy, slip in their shoe, cheap, that they don't have to think about, that they can easily replace. Basically a no-brainer. They're not going to be moving this around. So it's something that to me is an easy, I hate to use the word sale, but it's an easy education point. You have an arthritic joint, this is your solution. And that's to me how I integrate any product or anything like that into our practice. This is what you have, and this is the solution. So there's no negotiation. Like, you either want it or you don't. Like, I can't reinvent the wheel. I can't give you your cartilage back without surgery or doing something major. So at least this is going to take the pressure off of it to make them more comfortable. I haven't had one person come in and complain that they didn't like it at all. Again, but candidate selection is critical. Okay, so who is it? Think about your surgery patients, your post-op patients. You want them to stay off of it, and then you're transitioning them into a nice supportive tennis shoe. This is perfect to put that in there 3 months, 6 months, whatever it is. Ideally, you're pairing this with physical therapy, and the goal would be that they drop it even in 2 months, and then they're transitioning into a full custom orthotic. I think, to me, it's a good transition piece. It's maybe even a good backup piece in the future, but that you really need to identify, is it Hallux Limitus or Hallux Rigidus? So that is the big patient suitability issue, and telling the difference between the two. And it's almost a feel. I can't tell you, like, oh, if I can move it 10 or 12 degrees, you need to do this. It's, do I think this joint can function? And often what I'll do is put a Morton's extension in that shoe. Say it's bilateral. I'll put a Morton's extension in one shoe and I'll put the ProTech in the other. And if they tell me, they're like, oh, this feels horrible, and it's the ProTech, well, then I know, go to the Morton's extension. They're liking that. Their joint is ready to be offloaded. I think that's key. Is it ready to be kind of babied and just take the pressure and the tension of the joint and how it's jamming off of it? So to me, a biomechanical exam, I do it every single time. Now, am I doing the full gait analysis? No way. Nobody has time for that. But how easy is it to load that lateral foot and you play with the first metatarsal, plantar flex it, dorsiflex it, what's going on, and then, you know, uh, moving the hallux in the way that you want, to see if it's something that can be salvaged or does it need to be offloaded? Okay, who is not a good candidate? Someone with diabetic neuropathy, that truly does not have any feeling. We know there's many different categories of neuropathy. Is it burning, tingling, whatever it is? If they have numbness, then you probably don't want to have a rigid piece of material under that first met head, because they may think, I mean, it may be plantar flexed. That is a definitely an issue for creating an ulceration on that, and they wouldn't know. So definitely identify and make sure, when you're doing that Sims-Weinstein test, it's, before you give this insert to a diabetic patient. Okay, functional hallux limitus. What does that mean? We can still move the joint. So do not restrict a joint that wants to be moved. Now, if it's moving minimally and it's painful, that's a different story. But if it's moving and they're like, yeah, I feel it a couple times a week, no biggie, then I'm like, okay, let's do some type of a peptide injection. Let's do some laser therapy. What do we want to do adjunctively to getting the pressure off of it? So that's when you go with a plantar flexed first ray with a custom orthotic. You need to bring that down because they have hallux limitus, because why? metatarsals elevated. So the joint is jamming. So what I literally do is force that plantar flex down with my exam, and I say, hey, this should be 65 degrees. But because you're here, the joint is jamming and you're only getting maybe 30 degrees. And that's why you have chronic lateral Achilles tendonitis. Putting that together for them, it's like mind blown. And it's simply because of the range of motion of that first big toe joint. It is the most, to me, I know the Liz Frank joint, but to me, not identifying the range of motion of that joint dictates everything. Because if you think about it, if you heel to toe off, you have that joint jam, and then you go lateral. Well, what's that doing to the ankle, the knee? I mean, you're externally rotating everything, and you're getting that massive jam on the SI joint to the lower back and the butt area. So again, neutral is optimal. So make sure that the big toe joint isn't messing all of that up. Also, I mentioned briefly that it can exacerbate metatarsalgia. So if you put someone that has normal range of motion to that big toe joint with a Morton's extension, you're going to create more problems. So liposauna to me is my adjunctive. Obviously I've corrected the insert orthotic situation, but if they have metatarsalgia, my go-to right now is liposauna to create more fat. If this happens and the patient has severe arthritis and they have maybe the fourth met head is painful, what I do is hold that out. So I keep the Morton's extension, I take the pressure off of the fourth met head, I add a metatarsal pad, or even like a little U pad or something, dependent on the patient's arch type and what they can handle, to kind of compensate for that particular the way that you're rolling out. Of course, if you have a really complex foot, the way I look at it, it's like sometimes I'm like, okay, you have this foot is Hallux rigidus, this one's perfectly fine. And so you're trying to find that balance. That's a go-to custom orthotic. I mean, you can't get around that. When they have two different feet, that is always a challenge. Another thing to always look for is a limb length discrepancy. So if you have someone that is toeing off and you notice that this particular foot is more inverted, I always have them stand up, march in place, do all of that. And likely there is a limb length discrepancy that's contributing to that compensation. And it all comes around the first big toe joint. So I just put a little bit of a heel lift underneath of it. I will then build it in at a later point. But initially I want to play, because I don't want to correct too many planes at one time. I think it's too much. Sesamoiditis is indicated. I think I would love to hear Mindy and Mercedes. I was actually talking with Luke from the lab this morning, and I said, hey, like sesamoiditis to me, I know you have it as an indication. I personally would not do that because with sesamoiditis, of course, an inflammation of the sesamoid bones, but it can also be from number one, a plantar flex met. Okay, so if you have an extension and you're putting a plantar flex met on there, it's only going to exacerbate it. Two, you typically want to elevate metatarsals 2 through 5 to actually float the sesamoids. So to me, it's a contraindication. Test it out. Let me know. It's got to be here for a reason. But he and I just couldn't figure out why it was here, especially if you have severe sesamoiditis that's resulted in arthritis. That's a different story. That's a Morton's extension. Definitely. So I think maybe that's where the confusion is. But anyway, with those patients, I just don't want you to draw an immediate parallel to sesamoiditis, Morton's extension. Evaluate that one for sure. But I just think about how many patients just have arthritis in their big toe joint. It's constant. Okay, so what do I do? My little protocol here is, of course, what's going on, biomechanical exam, what's going on with the patient's big toe joint. I then layered that in to all of my protocols based around that particular exam. So if you don't have protocols, and I know you guys have heard this 1,000 times, I really recommend writing them out. We edit ours probably quarterly, and there's so much new stuff coming out. I highly recommend updating those because let me tell you, medicine is blowing up in our field and super excited for that. Anyway, long story short, educate your team as well. That's an obvious. They need to know when they go in to fit that patient for Morton's extension insert. If it's not feeling the way that the patient expected, number one, set their expectations. Number two, is this the right insert? So train them to come grab you, or ideally not. And you're like, okay, go try this one, and see how they respond to it. Just test it. I always tell my patients, I'm like, you know what? I have a billion things for bunions. I have a billion things for plantar fasciitis. We're going to bring a couple things in and we're going to let your feet decide, because that gives them autonomy in their own treatment plan. It also tells them that you're just not trying to sell them everything, that you're really critically thinking about what's going on. And often you don't know if you're going to like a shoe until you put it on. So, how is an insert any different? Of course, we always roll out seasonal promotions, and we use it as, we call it make it right. It's an omni concept. So if we make an error, we forget to schedule a referral, something falls through the cracks, I don't know, I will go grab them. Maybe they were scheduled to pick up their custom orthotics and they didn't arrive for whatever reason. I 100% will go grab them. Like, I am so sorry. This is on me. This is going to be a great backup, to your custom orthotics, or I'm sorry you drove 3 hours away, and whatever. Use it as your make it right campaign. You will 100% that roughly $20, whatever the cost is going to make a massive impact on your practice, and they're going to be happy. So that's the game, right? All right. So what can it do to you financially? I lowball this. If you do 2 a day, which everybody has 2 patients with painful Hallux limitus a day easily. Just having that built into your protocols is going to make a impact on your bottom line for about 32,000 a year. Not bad. They're coming there anyway, looking for this. So to me, it's a disservice if you don't have insert varietals in your practice, because they're going to go elsewhere, and likely online, and they're going to get frustrated. Well, I went there and they didn't tell me anything, because of course that's what they all say. But if you have a plethora of options to them, and this is one which is going to be a massive part of our demographic, why wouldn't you carry it? Well, I don't know if you guys do virtual stock, or that would be something to consider. That's the only thing I can think of is a space issue. But this is easy ancillary revenue to add without even thinking about it, because if you can't diagnose Hallux limitus by now, then there's something wrong. My gosh, this little window is just in my way. There we go. Okay, so what do I do? You guys know I love marketing. So what do I do? So I have a digital x-ray, and what I'll do is I'll pull up the lateral, and I measure the angles. I will show them the first metatarsal decline angle, and I'll show them where it should be. And I don't use, I use the numbers for the calculating inclination angle, but the rest of them I'm just drawing for a visual, because I don't want them to focus on the numbers. I want them to focus on the geometry of what's going on with their foot. So when I show them that, and I'm like, okay, this is where you are, this is where you should be. And they're like, oh my God, can I take a picture? So it's so impactful for people to see it, because us saying the word Hallux is already throwing them off. Us saying Limitus, they're gone. So if you show them, this is where you are, this is where you need to be, and this is what I have, or this is what you need, this is how arthritic, you don't have any range of motion, you're bone on bone. There's nothing we can do about it unless you want surgery. So this is your solution for them. I typically talk a lot with my hands, and I use foot models. Maybe because I'm a visual learner, I don't know, but I feel like that's super impactful. I will often use kind of that dead space in the shoe whenever I'm recommending a insert or an orthotic, anything like that. I'm like, look how, you have a calculating inclination angle of, 40 degrees. I'm like, look how much dead space you have in your shoe. It's really challenging for them to find anything, that fits. So I would recommend with their HPI, you pull specific words, buzzwords that they've said. I can't play with my grandkids in the yard because when I wear my shoes out there, it's painful because of blah. Okay, you have an arthritic big toe joint. This is an easy fix. Number one, what's the shoe look like? Probably crap. 2, throw that insert in there. You're automatically going to give them more rear foot stability and arch support, so they're going to like it already. So what they're dealing with, it's kind of a win-win situation. because you can't mess it up. They're already in pain. And now you just need to pull on that. I'm like, oh, okay. So when you wanted to go out with your, when you want to go out with your grandson and play in the yard, this is what's happening. And what I'd like to recommend is this. And then I don't talk prices ever at all. I tell them, I presented, different options to you. The girls are going to come in and review your insurance information and just let them know what you decide to choose. And I'll be back if you want to do something else. So anyway, it's not just about the insert. It's about the education, the expectations. I'm like, what do you want? If someone comes in, they're like, I hate my bunion. I'm like, does it hurt? No. So this is a cosmetic issue. I mean, because you don't have to have bunion surgery. Like, no, I have a bunion. I need surgery. That's what I've been told. I'm like, I would never touch you with a 10-foot pole. I'm like, this is ridiculous. Now, if it's a cosmetic thing, you don't like the bump, that's a whole nother story. And often they're just like, I don't care about the bump. So anyway, there's so many different things out there to add to recovery as opposed to, I've been in private practice for 18 years. And I was just taught like steroids was the end all be all. But now there's just so many things that we can get by with using a simple over the counter insert with an adjunct of regenerative therapy that's going to make them immensely, immensely better. Oh, that's it. I don't know the time. I've just been chatting away. How am I?
You're great. You ended at 8:35, and I love how you're like, oh, that's it. That's
How boring
amazing.
was that?
How what?
How boring was that?
Oh, not boring at all. Like you talk a mile a minute, so you have to actually pay
I
attention.
do. You have to
Which
put
I
me on like
like. I like. I
0.75.
like.
I just get so
Yeah,
excited. I'm just like,
I know. You can tell. It's good. All right, so we've got a bunch of people on here, but no questions in the Q&A box. So, if y'all have any questions about, what Dr. Freels talked about as far as treatment and all that, or product related questions, you can just pop those into the Q&A and we'll get those answered. But
I have a question.
while we're waiting,
I have a
yeah,
question. So if no one has a question, then why are you on here?
I know, right?
There's got to
Well,
be,
they're coming
because
in now.
everybody
Here we
knows
go.
and everybody knows what a Morton's extension is. I mean, that is day one podiatry. Everyone knows PowerStep, day two podiatry. It's simple to me.
I love how you're like day two podiatry.
It is. I mean, like there's so many out there. I mean, but my grandfather had PowerStep inserts in his office in the 90s. So that's the only one I've tried, of course, all the others. Oh yeah, we have a question.
Yeah. So, in a world where people can return anything for any reasons, how do you handle returns?
We actually typically don't get returns. If any return we get, it's going to be on our L1971 or an L1902 ankle brace. I never, if someone, it does, I've never had one be returned. Now, custom orthotic, we have a 2% unsatisfaction rate. They get a free PowerStep or they get a free whatever. That's the make it right. But going back to school to become a certified podorthist, I think has really minimized my learning curve with any over-the-counter product. But maybe we should do something more clinic based and then really do a webinar focused on truly like over-the-counter orthotic problems. I mean, we could just hammer down some, what's going on from either a lab communication level or a product selection level that's just not meshing with that patient and kind of say, okay, let's break this down. Patient diagnosis, whatever. Ooh, one
That's
thing I will
awesome.
tell you, sorry. Patients that have neuropathy and they're like, I hate it. I hate, that frustrated patient. I always ask them, do you like wearing socks or do you have a hard time wearing socks? I'm like, I hate socks. They can't even wear a Band-Aid comfortably. So it's any type of pressure and irritant. It's not the insert fault. It's the hypersensitivity from a nerve level. So that one took me a lot of years to figure out because I'm like, no, it has to be this. Nope. Nope, nope, nope. They're too sensitive. Just yank it out. Just say, hey, here's your, money back or whatever, or keep it, throw it away. So
Huh. All right. Starting a new practice. What's the best way to go about getting PowerStep in my office at the most cost-effective way possible? We all know they're the best OTC insert.
I can take this one. That's really exciting, and congratulations on your new practice. So yeah, the first thing I would suggest is that you could reach out to our customer service and they can put you in touch with a sales rep who will work with you directly and figure out the best selection for your office. And you can also get samples from them to try out and test. We also have a program that if you are you not interested in carrying them in office, although there's benefits with it, as Dr. Freels just explained to us, we do offer an online referral program. You could actually do it in conjunction with dispensing them in office as well, where you would refer out to PowerStep.com and with a code, and your patient can purchase them there, and you can earn some percentage of the sales that are accrued through that as well. So any sales rep at PowerStep would be able to help you answer any questions you have regarding that as well.
I personally think having them, sorry, I didn't mean to interrupt, but I want to make sure I got my thought. I personally recommend having them in the office, and I've recently onboarded another product line that's in the supplement, and he was telling me that he's like, you have it for the first one, and you get them on the board because we're needy people, right? We want it yesterday, and if you put it in their shoe and they feel it, that's a game changer. The product speaks for itself, and if it's the right candidate, then it's going to work. However, what I would love is a recall program from PowerStep's to be like, okay, this patient got ProTech High, full length. And then you guys come back and reach out to my patient in 6 months and say, hey, how's this holding up? Do you need, and then we could go to a virtual program where we get a percentage of those sales and you send it directly to the patient. Yet you're still, you know what I mean? It's like a follow-up, like a nurture campaign.
Yeah, exactly. And that's something that's an interesting perspective on it that we should offline and talk through. But I really like that idea. But yes, anytime that you refer them to our website, they're shipping it direct. You don't have to worry about the hassle of collecting payments or having them in office for them to pick up later. It's all simple. And then the returns there, if we have a satisfaction guarantee on PowerStep.com. So if anyone needs to return one, it's just a simple standard return through the website.
Every podiatrist is looking for mailbox money right now. Every doctor is, I think, at this point, looking for ancillary revenue that is like, we've already done this. Why not get the long-term journey of the patient from a revenue perspective? If
That's a good point. You could carry in office and get that larger margin, right? And then if they need refills, is that the word? Another pair down the road to replace it, I guess is the word. Then they could use the referral program for that without having to come in for another appointment necessarily to schedule it.
Yes, exactly.
They work really well in tandem, and they accrue for quarterly payouts. So that's just a nice little ancillary side income stream through the practice.
It literally wins for PowerStep, the doctor, and the patient.
All right, we do have a few questions now. It's very exciting. All right, I apologize if I missed this, but for the sesamoiditis and functional Hallux limitus patients, what kind of product do you recommend? I've had difficulty finding OTC reverse Morton's orthotics.
Well, that's when I would do the custom. I would do the reverse, and then, so is this for sesamoiditis or is this for a plantar or Hallux limitus? Because to me, I got to separate those two. Those are two different demographics. So let's do sesamoiditis. Okay, sesamoiditis, let's do a reverse Morton's. I would do a metatarsal pad. Boom. There you go. Make sure the shoe isn't flexing too much in the forefoot. That's going to be a constant irritant that they'll never get over. So it doesn't matter what insert you put in there. The shoe is critical. Like, I hate when people come in, they're like, they haven't looked at my shoes. I'm like, you're fighting a losing battle because you got a great shoe and a shitty orthotic, or you got a great orthotic and a shitty shoe. It's put them together. I say you're doing a disservice to your feet. You're fighting, you're making them fight against each other. is what I say. So that would be my design for sesamoiditis. So again, reverse, and then metatarsal pad, nice cushion. I think that's it. And the solid heel cup. Definitely always, always, always a heel cup. You have to control that rear foot with a semi-firm, semi-rigid shell for an insert. For Hallux Limitus, you want just, it's very simple. And I don't know why they didn't teach us this in podiatry school to this level. I learned this in the podorthic courses I took. First ray cutout. Game-changing, like literally the number one feature to tell your lab on a consistent basis that you need. If they do not need a Morton's extension, I do 100% of them with a first ray cutout. If they don't need, because more than likely they have Hallux Limitus. I think it's the most diagnosis foot issue ever, personally. I wrote actually a big article for physical therapists about it. I'm like, what you're not looking at. And they were surprised. They're like, yeah, we never look at that. And I'm like, why do you think his knee's hanging out there? You know, it's like, look at how the big toe joint's functioning. I mean, everybody thinks it, you know, or everybody knows you lose your big toe joint, or they think, right? Then I can't walk anymore. How am I going to do it? Well, why do they say that? There's actually a reason behind it, but we don't institute and implement it in our practices.
Yeah. Do you have any resources for size 20 athletic shoes? The patient had been wearing New Balance until they stopped manufacturing shoes larger than size 16.
You know what I would do? Ask ChatGPT. I have no clue outside of working with a company that would do a custom shoe. And I know they're out there and I know they're so expensive, but this guy's got to be a one-off. I think this person just probably needs to find a custom, and they're out there, they're online. And I think that's a patient discovery issue and not a podiatrist discovery. I mean, unless you wear a size 20, then that's a you problem. I mean, I have no idea.
Custom orthotics are getting more difficult to get covered and patients are hesitant to spend. That's just a comment, I imagine. Also, the comment from the guy earlier starting his practice said, I'm a couple months out. I'll reach out to a regional sales rep. Nice talk. Thanks a lot. All right. I know you discussed this.
Read the one that you just said, because that's, to me, I am the top 5 in the country for making orthotics or dispensing orthotics through Anthem. Not bragging. I'm a red flag. They tell me all the time. I'm like, I do sports biomechanics, all that crap. So whatever. It's all about your education. I hate the word education. It's all about the pitch, to be quite honest. It's how you are presenting it and what form. Don't do too much. Don't do too little. It's connecting the dots to what they said. And I probably should just do another whole thing on that, because getting that down would be a massive game changer for your practice's bottom line. Because we have tons of cash. I don't care if they're covered or not. I don't look at if it's covered or not. I go in and I'm like, this is what's going on. You know, I would recommend blah, blah, blah. However, we have excellent medical grade inserts that are available if that doesn't fit your budget. And that's it. I'm out. So I don't look at the insurance, because I refuse to insurance profile people, because I don't want to be my brother, who does very well. He doesn't even have insurance. He works lumber and hardwoods. He looks like dirty as can be. That is not, you know what I mean? You tell him like, hey, you need $1,000 pair of inserts. He'd be like, okay, great. You know, it's Kentucky. You can't judge people on the way they look here, because they're all rich horse farm owners and stuff.
I remember one time on a previous webinar, you said something about how, because you're trained as a podorthist, the way you talk to patients is different and can be more compelling. And you said that we should do a webinar on that. So I think that would be a good follow-up for another PowerStep webinar.
Yeah, just bridging the gap. Like, I had to go get that certification because I could not communicate with my lab. You know, I was jumping lab to lab, and I'm like, something's wrong here. And I learned during the process that how podiatrists in the terminology that we were trained with is completely different from the lab terminology. And so I was able to, you know, bridge that gap and make it make sense for me. And then the success came from that, just having that knowledge. Yeah, I think that'd be a great webinar.
Yeah. Mindy, this might be a question for you. Not sure about the pricing when 2 feet are different because they're sold in pairs.
Yeah, that's a tricky question. The insoles are trimmable to an extent. So that could be an option, is to size a little bit up and then trim it down for the 1 foot that's smaller. You want to be careful not to trim too far because you could affect glue and all of that with the insole. But how do you handle that, Dr. Freels, in your practice?
I've actually, right now it has to be a custom. I have already, with your lab, discussed the importance of that exact question, because I told them, I was like, it's typically not symmetrical, especially in that 40 or 30 to 50-year demographic. It's asymmetrical because it's typically occurring in 1 foot for excessive pronation on one side or not. So to me, I'm working with Luke to be like, okay, this needs to happen. How can we make it? So I'm hoping that we will, over the next 6 months to a year, be able to come up with a design that makes sense. Because I mean, can I get like a high five for anyone that would want that insert or like a hand or something in their practice? Or maybe it's just me. I don't know. So just do custom, I guess. Yay. Thanks for the thumbs up. Oh, 2. Feel special now. They're paying attention.
All right. Custom orthotics are getting more difficult to get covered. Patients are hesitant to spend and possibly be dissatisfied. Is there any way to modify the OTC orthotics to make the first ray cutout?
There is, if you have a grinding wheel, what you're going to want to do is, now, of course, you're going to rip up the material. So I would have some moleskin on hand. Obviously, turn it over. Look at the distal medial portion of the shell. Skive that at a 45-degree angle. That's going to get you smooth transition down. That's going to get you a cutout that will be satisfactory. It may be a good introduction to the patient as well, of maybe moving into custom. I don't know. You could test it, because that's why I love OTC, because where they're so inexpensive, they're, to me, very easy to dispense. And my goal is to transition them long term to a custom, or at least have them, repeat buys. I mean, because that's, we need that recurrent revenue, and they need it. I mean, I've been in orthotics for literally 40 years, since I was 8. So I'm a huge believer.
Somebody said that the PetOrthist seminar or webinar would be great, so we should definitely do that. A question about, what's your mastermind group about?
Oh, so that is called Toe Tactics. It's Podiatry Innovators Hub. It is a private group. You can actually just email me and I'll give you access to it, because again, it's not something that's easily discoverable. There's I think we have like 560 people. I just started in April to have a place where we can all be safe, and then we can all work together, especially as private practitioners. I feel like, no offense, Mindy, Mercedes, a lot of these reps just really take advantage of us, and where we're so siloed in private practice, I've just been taken advantage of so many times over 18 years. And so I wanted to do, if it's bulk ordering, if it's really just about, like, I love AI and marketing, all the new stuff coming out, peptides and regenerative medicine. And so that's kind of like my dumping base. And then everyone just dumps their issues, but it's a highly secured platform. So yeah, definitely email me, and then I'll give you guys the link. Or just, if you're on Facebook, go to Toe Tactics, one word, Podiatry Innovators. It'll populate. So the page, I haven't done anything on the page. The group is where it's at. And it's like a no BS group. Like, this is, if you don't know what you're doing yet, don't get in there. We're only looking for progressive podiatrists that, or from a mindset perspective, not from an experience perspective. I want people that are open to new stuff. I don't want the old farts that are like, no, 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 because I've heard that for years. I'm like, yes, yes, yes. How can we do it together?
Yeah. There is a comment here. Apis does custom shoes. So that might be something for that doc that was on here that has that patient with size 20 feet. All right. I think we've got everything. Do you guys have any, oh, Dr. Freels, where can we see you? Are you going to any conferences? Are you lecturing anywhere? Where can we see you?
I'm going to Foot Fest next weekend, which is being held by, it's called a Gate Happens. And this is actually a really good group for these people that care about biomechanics and orthotics. It's specifically geared towards podiatrists, physical therapists, sports like trainers or whatever, and chiros. And it's all about connecting. It's put on by chiropractors, which, you know, they have how they have bridged the gap. Their focus is feet and how that's affected the entire body and the entire chain. I've passed level 1. I'm going for my level 2, and it's really like they've got some good stuff. Like I was impressed. I'm like, this is new biomechanical material as opposed to that regurgitated root, all of the concepts and the history behind that we already know. This is clinically based that applies to your practice. So I have that one. I have Sam in January. I have Louis DeCaro. Oh, that one's next week. That one, and then we do like webinars every month. I don't know. I feel like I'm everywhere right now.
Yeah,
everywhere and nowhere. I'm like getting sick of myself. I was like, I'm just not, you know.
No, I think that's good. Okay, so any final comments from Dr. Freels or from the PowerStep side of things? Anything else?
I'm good. Just feel free.
All right. I think we're doing great. It's 8:56, so like we're right on time. We finished all the questions. Thank you guys for joining us. Thanks for being here and spending your Monday night with us. Looking forward to the next one, which I've been out of town for the past week, so I really can't even, my brain can't think of what the next one is, but I know there is one coming up. So I hope to see you all there, and we will see you next time.